one of the things I just thought, obviously the title of the webinar, sorry, we're going back to the title of the webinar there, is The New Well-Led, so Key Lines of Inquiry in 2019. Just to give you a bit about where this webinar is coming from, we run our quality practice scheme, and we also do audits on practices as part of that and separately. And my team and myself have been auditing practices for years. And what we see, even in the best practices, who are trying really hard, we do see key errors time and time again. And so what I want to cover is, and quite often, and to be honest, the CQC are finding this too, and they're finding it more. So what we're seeing and why practices are failing inspections are very much the same thing. And I want to talk that in context of the changes to the key lines of inquiry last year. You may or may not know that they completely updated the key lines of inquiry for all healthcare providers on the 1st of April last year. So, but the impact of that on inspections has been interesting. So we'll talk about that as well. So that's what I want to talk about today, just to give you that information of what's going on. I thought it might be really, really helpful first to skip past that slide and to talk about hot topics. So just to give you a little bit of what's going on right now and what seems to be important or what looks like it might be important in the future. At the top, we've got safety alerts. So with your safety alerts, if you are an iComply subscriber, which I think about 75% of you are, so thank you for the people who are members for being on this, and thank you for the non-members for coming in and checking us out to see what we're all about. Safety alerts, you've got a safety alerts policy in iComply. Now, the safety alerts policy is actually very, very clear on what you do when you get a safety alert from MHRA or CAS. Actually, it's pretty much the same now. But a lot of you, what we are finding is a lot of members don't actually follow their policy. So your policy says that when you get a safety alert that you think could be relevant, you'll log it on one of the G110, the event forms, and you'll put it on the register, investigate it, write some notes. And invariably what we see in practices is when you're getting a safety alert, you're maybe just putting it in a file and putting a signature on it that wouldn't really tell an inspector what you've done, and actually isn't what your policy says you've done. So we're finding this in a lot of practices. So I'd go back and review your policy and just see how you deal with it. If you want to do it differently, obviously, our documents are templates. If you have a better way or what works better for you in a practice, then feel free to edit the template, but just be careful of having something written down that you're not following, because obviously that could slip you up. So that's safety alerts. Sepsis. This is a really, really hot topic right now, because effectively some patients, some practices in the last few years have not either spotted a patient who presented with sepsis, or a patient has been sent away with antibiotics because there's an abscess that they couldn't completely drain, and they and the patient wasn't told, by the way, there's a chance that it could turn into sepsis, and if that happens, these are the symptoms and you should call 999. The CQC are really, really hot on this at the moment. So our updated referrals and sepsis policy has all the info in that you should need, and there's links to the UK Sepsis Trust where you can download and put posters up in your waiting room, and there's a real emphasis for you to train both your front of house and clinical staff and just make sure that they're aware of those two scenarios. So a patient presenting with sepsis or a patient being sent away with antibiotics. Moving on, urgent referral management. I'm going a bit quickly today because I've got so much I want to tell you. So, if you do have any questions, then you can type them as we go along, and we'll try and deal with them mostly at the end. But urgent referral management, very, very simple. If you're sending someone off for an oral cancer referral or something like that, you need to be able to prove that you checked the referral was received. Ideally, you'll have we haven't put this in iComply because it would just be a very simple spreadsheet that you could create. Ideally, you could create a log that just says, that you can show where you followed up on it. Or at a minimum, and I've heard this direct from the heads of inspection the last time we met with them, so the heads of inspection at the CQC basically said, as long as it's written in the clinical notes, so if your receptionist can ring up or whoever's dealing with it and then just type it into SOE or whatever you're using, The website is the UK Sepsis Trust. If you are a code member, it's in the referrals and sepsis policy, which is M233 hyphen, I think it's RFL off the top of my head. So that's sepsis and urgent referral management. Accessible information standard is way too much to go into in this webinar. The CQC seem like they've started to look at this now. And it's mostly for people with NHS contracts. There is a policy in iComply. If you're not sure, if you have an NHS contract and you have no idea what I'm talking about, then just have a look at the policy and figure out from there how you want to implement it in your practice. Complaints handling. Complaints handling, part of one of the things that we've done at Code is we're part of a group called the Complaints Handling Initiative, which is 29 organisations involving the GDC, all the defence organisations, all the professional associations, and we've been sat around a table for the last couple of years talking about the issues with complaints handling in dental practice. Now, we've released a whole set of documents in iComply to incorporate these principles. So if you've not had a chance to read the updated documents in iComply, I'd have a look at that. The GDC have created a poster. There isn't a GDC poster, it's been created on behalf of this group. The GDC are the custodians of the poster, as it were. It's an A3 size poster that it would be a good idea if you had it in your practice. You don't have to do it. It's not a GDC standard, but the problem is that patients, when there's a complaint, they don't necessarily know who to complain or where to complain, so they end up going to the GDC, which is something we don't want. So I would encourage you all to consider putting that poster up in your practice, and I think it would impress an inspector as you going above and beyond what's required. If I had a practice, I'd have it up, so it's up to you guys. Antimicrobial prescribing. We're seeing this, it's from the GDC website. You can literally speak to the GDC and they will give it to you. So it's on the GDC website. I think if you Google GDC Complaints Handling Initiative, you might find it under that off the top of my head. Antimicrobial prescribing, they're starting to look at this a little bit more. The word from the CQC a year or two ago was the audit isn't mandatory. However, the NICE guidelines and the FGDP guidelines on antimicrobial prescribing, I mean, the FGDP guidelines I think were updated last year. So it's getting a bit more serious. So you might just want to look at it, but I wouldn't consider it mandatory yet. This is more of a prediction. Risk assessing we're going to talk about a lot throughout this presentation, but essentially what people are finding, what the CQC are finding, what we find is that people who aren't risk assess trained, who have no formal training in risk assessment, are carrying out risk assessments, and therefore they're misusing the templates and potentially putting you as practice owners in a dangerous position if something happened and the HSE got involved. So we'll talk about this a lot throughout this presentation. Sedation, if you are an iComply application subscriber, we've released a load of sedation guidance, which we wrote in collaboration with one of the guys who wrote the official, the IACSD guidance. So that's a benefit of being an iComply application member. So we've got some audits in there that you can use and guidance on documents that you need to create. There's a lot that you have to do in practice for sedation, and the CQC have said that sedation is their big red flag. So if you're not following sedation guidance, the latest, the 2015 guidance, and they inspect you, that could be a very, very big deal. Cool, so that's kind of hot topics for now. So what I want to talk about in the rest of this presentation is the 2018 key line of inquiry changes, why they are generally not that important that the key lines of inquiry changed. It was kind of more of just a reorganization internally in the CQC and a bit of an expansion of what they're looking for. But practically, they're looking for most of the same stuff apart from well-led, which is where if a practice is failing a CQC inspection, 100% of practices that fail on the well-led key line of inquiry, at least. So that's really, really important. What is this being well-led about, and how can you be well-led? It's mostly about competence, capability, capacity of leadership, a lot about leaders and managers, and about have you got the right people? Are you giving it enough time? If you're delegating it, are you training the people you're delegating it to? Or are you asking your poor trainee nurse to do a radiography audit and she doesn't know anything about IRMA? So your audit ends up getting you in trouble, and then you look like terrible leaders and you fail on being well led because of that whole chain of events. So we'll talk a bit about that. Quality assurance and having a governance system, and then and following that governance system, and also, so I might give you a couple of iComply tips as well, and also just peace of mind of how you can be sure that you are well led. You'd be surprised the number of practices we visit who have very dedicated managers who are on top of iComply, but they may have just got the wrong end of the stick on something, and that's potentially got them could get them in trouble. So maybe we can help you out to sort of stay on top of this and know that you're actually using the software properly, and that what is in your practice, in your files, is actually the sort of evidence that the CQC are looking for. So we'll talk a bit about that as well. So, moving on. So last year, 1st of April 2015, so these are actually the changes of what actually happened, but I'm not going to go into it in too much detail on safe, caring, effective and responsive, because there's different teams in the CQC, and what this kind of looked like was that the sort of the guys who are on the policy team of how they do things generally, and the dental team were doing different things. And that the dental team were actually, it seemed that they were quite happy with the inspection. This is just my interpretation. I don't have any inside knowledge from the CQC on this. But what they did essentially is they took all the key lines of inquiry from all healthcare and they turned it into one set. So what we actually lost in that was the really good guidance on the key lines of inquiry that was in the dental provider handbook. Because they've kind of put it all together and they created these new key lines of inquiry with examples of evidence and expanded key lines of inquiry. And they did it on the 1st of April, and we actually were emailing, in constant contact with the heads of inspection, just to make sure that anything we put into iComply, well, just to make sure if we needed to put anything into iComply, and we've finished that job now. So it was an ongoing job, took about 12 months to get it really, really spot on for you guys. But, you know, people with iComply are 10% more likely to pass inspections. So it's the job that we've done has been really, really solid for you guys. So what actually changed was the way that they looked at well-led. That was the main change. The other things are basically the same, and they're not inspecting you differently. So don't worry about safe, caring, effective and responsive and any changes, in my opinion. Be concerned about well-led and what that really means. So moving on. So this is where it comes from. The CQC, they did this strategy in December 2016, and what they said is safety is their biggest concern, but it's influenced by the quality of leadership. And we're going to go into that a lot. The quality of leadership. How are your leaders and your managers? How well trained are they? If they're a registered manager, could they set up a practice from scratch to meet the regulations? Because as a registered manager, your job is to make sure that you're meeting the regulations all the time, at every part of every day. If you don't know what the regulations are, and you don't know what a compliant practice looks like, how can your practice ever be compliant? So just moving on from that, so then their increased focus on well-led, what they actually said is in strengthening their assessment, they're clear that there is a demonstrable link between leadership culture. You know, does the leader, does the principal care about compliance? Do the managers think that it's a worthwhile thing? And the delivery of safe, high-quality care. So they're looking into this more, because essentially what they've found is if the principal isn't up to date, if the manager, or they're not using a good governance system, and the managers, you know, they've not been on any CPD, and they don't care, but they're also telling their team they don't care about compliance, then the compliance is going to be rubbish, right? So we'll look into this, but there's nuances in this, and there's sort of small mistakes that people can make as well as the big mistakes around leadership. So let's carry on and look into this. So what we've done is, and for those of you who've seen the history of webinars, you've seen this slide develop over the last 4 years, but we've looked at about 2,500 inspection reports, and we've analysed and put them on spreadsheets. We've done loads of work on this over the last few years. So this is why we can say this stuff with confidence to you. So I've personally read about 1,500, and they're really, really good, by the way. If you really want to learn more about compliance, if you are the principal, the registered manager, there's very few better places you could start than actually reading reports of practices that have failed. So you can always have a look on the CQC website if you're into that sort of career development and you want to get there and show this. So in those 2,500, what we've found by now, by 2019, is about 15% are found to be in breach and have failed their inspection. So this is what everybody says. The practice gets shut down immediately. It happens so rarely. For any of you who have seen me talk about this before, the actual scenario, if you're looking for a scenario to avoid rather than just being a legal practice, the scenario that we're trying to avoid is that you get a report online that says that you're poorly managed and unsafe. And then what happens is your local newspaper gets hold of it and it's front page news. Local, and you can imagine that with your local. We've got the Argus here in Brighton and Hove, and you can imagine a dental practice being on the front page because to a local newspaper, it's a big story. It's an interesting story, and as Victoria says, that then will massively affect your reputation. And in a practice, your reputation, your goodwill, is your practice value. Yeah, so it shows on the website, Simona, and then in that scenario, you may. People love scandal. Yeah, there's always, I don't know about you guys, I'm an ex-practice manager for those of you who know me, but there's always one patient who is the head of the local church council or the PTA chair or someone who would love to have that information. Now that is what you're trying to avoid. On the other side of it, being compliant is just running a legal dental practice. I always say this to people that, we think of this compliance because a lot of us were in the profession before the CQC started checking it. They didn't invent it. A lot of this was stuff that we were actually supposed to be doing and laws that we were supposed to be meeting. So we'll get to this a bit later, but I'd encourage people to never think about being behind on compliance. Because if you're behind on compliance, with policies, fine, something like that. But if you're behind on, say, a health and safety risk assessment review, and you've not done it in a year, you've broken the Health and Safety at Work Act. That's finable. If you're behind on your 12 monthly X-ray quality audit, you've broken the IRMA regulations, and those are breaching laws. So I know I'm being very black and white here, but what I try and encourage everybody to think about is you may get the CQC are being a lot more gentle these days, but you may get an inspector who's had a bad morning and just wants to throw the book at you. If you've actually breached a regulation, then you've breached a regulation and they might not want to give you the benefit of the doubt because you have broken that law. There may be a good reason for it, but at the end of the day, so that's what I always try and think people want to try and avoid. So going back to the slide, so 100% of the practices that are failing that we've looked at 2018 to 2019 are failing on the well-led key line of inquiry. So if you're going to fail, it's generally going to be like that. So we will look into that. What our research has also shown, based on basically a freedom of information request to the CQC, well, an unofficial one because we have a good relationship with them, is that iComply practices have a 98% pass rate compared to 85% without iComply, or the rest of the profession, as it were. So we have you're 10% more likely to pass with us, which is great. These are what the new key lines of inquiry look like for well-led. And I'm not going to go into them because I've got more stuff on the next slide that's more important. But you can have a quick look at them now. Number one is really interesting because this was quite new, is the leadership capacity and capability. I would also add competence because someone can be capable but not competent because they've not been trained yet. So competence, I'd say, is a big issue that we find as well. But they sort of wrap that into capability as well. And the bottom, where's the one I'm looking for? And the bottom one, W8, is all about the learning and continuous improvement and quality assurance, which if you've seen me ever speak, this is something I've been talking about for the last 4 years, that iComply should help you in it to demonstrate this if you use it the way it's been designed. So what we find is quite a lot of people aren't necessarily always using the brand new features. So I'll talk about one of the best new features in iComply and how you could use that to cover off this problem that we see in practices. So moving on. So the well-led report section. So when you get a CQC inspection report, there's a section on well-led, and left is the pre-April 2018 sections, and right is the post-April 2018 section. So you can see that it's almost doubled the stuff that they're looking at, and it's got a lot more granular. The most important ones in here being leadership capacity and capability, culture, being all flows from the leader and how they feel about management and compliance and things like that. Vision and strategy, you don't need to worry about. They're not going into detail with this with a dental practice. They're not asking you for an actual strategy document. So don't worry about having a strategy. And then continuous improvement at the bottom is really, really important. So I want to go into the capacity, capability, what we see and what the CQC see. So leadership capacity. I'm going to use capacity in terms of this about time and time to do the job of being a registered manager or staying on top of compliance. We would recommend about 8 hours a week to stay on top of it. And that's quite comfortable. To be honest, after you've had it a while, you could do that a lot more quickly than 8 hours, but 8 hours is a good amount of time to dedicate to it. So any principals watching this and thinking, that's, I'm not going to give my manager that, which we do see occasionally, that's fine. But if you don't give your manager that, you're potentially going to end up in that scenario where you fail an inspection because you're not giving it the amount of time it needs, and the CQC write that you've not been giving it the amount of time that it needs. So if you actually look at these are quotes from CQC inspection reports on the monitor. So if you look at the top one, the lead dental nurse and the principal dentist were in charge of day-to-day management. Now what they mean by this is compliance. They allocated half a day a week each to do it, which is 8 hours a week, not a day. They allocate half a day each week to do this, though it was often used up for complex treatment. And I've helped clients in this scenario where the manager is based on the desk, which is something I personally generally don't recommend unless you're a tiny practice. Your manager is based on the desk, and then they've also got a GDC registration, and then you're expecting them to do 8 hours a week on the desk, and then when an emergency comes in every week, that 8 hours a week goes out the window, and then suddenly you're 8 hours behind, then the next week you're 16 hours behind, and then suddenly you've still got that ongoing 8 hour a week commitment, but you're a month behind, you're 32 hours behind. To catch up would take you 40 hours in 1 week. So just think about this. I'd love people to stop thinking of being behind on compliance. Think of compliant and non-compliant, and that might help you out better just to think about how important it is and how much it could affect you. The second point on the bullet point was, we found that the practice owner did not provide effective leadership due to being the registered manager, so being legally responsible for compliance, but also being in surgery 5 days a week. It's just not possible. So the CQC pulled up this practice and failed them because the clinician had registered himself as being legally responsible for making sure all this stuff was happening, and then he didn't give himself the time to do it. So these are just like really key things. Just give compliance the time it needs and try to not think about being behind on it, or try not to think that behind is something that's that possible. Policies and procedures, fine. Risk assessments and audits, that's what I was going to say before. It's really easy to prepare for an inspection with 2 weeks notice. If you're behind on compliance and you've got GDC registrants working in your practice, nurses who are not happy about this, then what can happen is whistleblowing. And we have this a few times a year where one of our members will ring us up, the principal, and one of their nurses or team members has been telling them for weeks that there's a problem, and they're sort of, we'll get to that. But the nurse obviously is a GDC registrant, and they have a duty potentially to whistleblow if they feel that the owner is not taking this stuff seriously, and then they whistleblow, or they quit and they whistleblow. So for me, I'm always, if I was running a practice these days, I am preparing for whistleblower scenarios. The worst case scenario, always, that's the way I think. So moving on. So that's capacity. So leadership time. How much time do we have for it? Capability. I've got a bit of capacity stuff, I think, on this slide as well. But capability, the management arrangements indicated that the practice fell short of clinical and managerial leadership because the audits and risk assessments were not effective. So I've actually got more on this on later slides, but it's just, we want to avoid a scenario where you've got the blind leading the blind. If the principal is the registered manager who's not necessarily on top of the latest compliance knowledge, doesn't know what the CQC are looking for now, or hasn't stayed up to date with regulatory changes, and then they're delegating that to somebody else who is being led by them, then potentially you've just got a cascade there of in the nicest use of the word ignorance, of just ignorance. and that can actually affect you. So we'll have a look at that. So because of that, you can see this is a different practice, but areas requiring improvement had not been effectively identified by leaders. Now, this is usually coming out of risk assessments and audits. Who's doing those audits? Are they competent to do it? Have they been trained to do it? And therefore they're not identifying problems. The third bullet point is just a very similar thing. This was just basically, the CQC don't look at clinical outcomes. So on that third bullet point, what they actually identified was that the principal dentist just didn't know what the regulations were. They hadn't kept up to date. So you're seeing a theme here, which is the people who are in charge of compliance need to be up to date. If you actually look deep within I think it's in the Health and Social Care Act, or it's the registered manager bit of the regulations. There's actually a bit in there that says that no one's actually tried to enforce yet, but actually says that registered managers need to do CPD and stay up to date, which is great if you've got a GDC registration. And we'll talk more about how you can achieve that at the end. The bottom one I put on, because we hear this a lot. I had a practice ring me up a couple of weeks ago, and they were a bit annoyed that they'd failed their CQC inspection, and the CQC inspector hadn't been empathetic to the fact that they'd had a high turnover of staff. But it's irrelevant, isn't it? If you've breached a regulation, you've broken a law by being non-compliant. It's not the fact that you've had a high staff turnover. Unfortunately, why is that happening? It maybe even raises more alarm bells about the managers and the leaders. If you're having a high turnover, what's necessarily happening for those people to keep leaving? I once had a client before I was with Code who asked me to come and look at his practice, and he couldn't understand why his staff kept leaving the practice. He couldn't understand why his team kept leaving the practice. He's like, I don't understand. It's a lovely practice. It's really high end. We do great dentistry, but they keep going. And in a nutshell, it was basically because he told them that the ethos of the practice was treat everybody as you'd like to be treated. But then he was late every day for work and made his nurse work through the lunch break. So I had a hard job of telling him after 2 weeks that basically everyone's leaving because of him. And if he wants them to stay, he needs to act in line with the practice mission. So it does happen. Not as much as it used to, but it's just really good to bear it in mind that if you're telling the CQC, I've got a high staff turnover, so I broke a law, then that could raise further questions. Right, moving on from that. So delegation not enough. So really good phrase that I like on this is that you can delegate accountability. Sorry, you can delegate responsibility for a task, but you can never delegate accountability, because if you're a registered manager, the buck stops with you. So there are different ways that you can delegate. So the registered manager may have delegated, maybe the principal, maybe really busy, and delegated compliance management responsibility to the practice manager. And then this scenario can happen on the slide, and we do see this every now and again. The principal has accepted that they don't understand compliance. They've delegated that role to the manager, which is fine. The manager is knowledgeable, they've been recruited, they know compliance, and they are telling the principal that they're non-compliant, and the principal is going, yeah, I don't want to do that though. Or or a classic one would be, well, I need to put the price list up on the wall. Yeah, but it's going to look messy on the wall. I don't like that. Or things like that. So these scenarios you do see again and again where the practice manager is talking to us. The principal's asked us to come in to assess the practice, and we're in a room with the practice manager who's telling us that the principal doesn't listen to them. So if you're in that scenario on either side of that as the principal, you've just got to think that could come back during the CQC inspection. Yeah, Simona, price list on the wall, GDC standards poster needs to be on the wall. These things cannot be in a booklet. Like, if they actually have to be displayed. It's quite clear about displaying. So there's that one. Also with delegation, we delegate certain roles to certain people. So say checking the emergency drugs, making sure that the autoclave logs are filled out, making sure that checking emergency drugs, autoclave logs, making sure there are no out-of-date instruments, in making sure no out-of-date instruments are in the drawers each day, and your nurses or people you delegated these to are ticking these boxes on these sheets. And I would say probably only maybe 50% of managers are actually double checking that they're doing the job. So what happens is when we go and double check, when we go and visit, what we find is there's a problem. There's an emergency drug that's not been checked, or they were only checking the dates of the emergency drugs and not the dates of the needles. Those weren't on the spreadsheet, or they've edited this. They've with all the best will in the world, this nurse has changed the spreadsheet to try, or the log to try and make it more concise, and has kind of lost a bit of the meaning of what it is. So, but they're also not being led, because the person sort of said to them, "Can you do this job?" "Yes, you can do it," and then they've not gone back. And then they've not gone back to double check that they're doing the job properly, or maybe even the person who's delegating it to them doesn't know how it's supposed to be done in the first place, because they're not up to date, or they don't quite understand the regulation, or something like that. Spot checks once a month. That's the solution. And what you may have noticed is with quite a few of the logs in iComply, we're adding these spot checks because we're seeing these. Generally speaking, the audience that I need to talk to about this stuff are not the people who sign up during their lunchtime for a compliance webinar. So I'm not surprised that you guys are really, really on top of this. But these are all just things to bear in mind, the double checks, everything around that. So that's delegation is not enough. This one's really, really simple. You may know that you are the complaints manager, does your receptionist, does your trainee nurse. There are certain legal roles that you have to have in a practice. And does have that has been communicated down the chain? Does everybody know? So, quite often with iComply, people sometimes, well, not quite often, but people sometimes skip the meeting at the end of the month, which is where you discuss if you changed a role, or who's in a role, or remind people. I'd really strongly recommend that you do those meetings at the end of the month, because that's where you give that information to the team. So just moving past this slide. Competence. So the top point here basically is a practice that isn't going to apply to 75% of you in this room, but this is a practice where they didn't have a compliance system in place, and they hadn't been going on CPD, they didn't have any accreditation or anything, no one's coming in and auditing them and checking it. So essentially you've just got two people working in isolation, and they think they know what compliance is, but unfortunately when the CQC go in, they don't, and they're 5-10 years out of date. I once went to one practice where it was a similar scenario to that. Lovely dentist, lovely nurse. They thought they were doing it right, but I always remember the nurse came to me with the Legionella log, and she'd been doing the water temperature taking in her surgery, and the box, she'd been doing it every single day, and she was really proud. And the box, you don't have to do it every day, but she thought she was going above and beyond. And the box, she was writing 30 degrees, 30 degrees, 30 degrees. The cold tap is too warm. If it's the hot tap, it's too cold. So what are you doing here? And she was like, "Oh, we've got a mixer tap. So we turn this one 2 turns, this one 2 turns, and then we take the temperature." She was really well-meaning. They thought they were doing it right, but they were in relative isolation. So most of you are subscribed to a system. I obviously would recommend a system, and if you want one, we have one called iComply. The bottom one's really, really interesting, because I've seen this twice in the last month from practices that are really good practices as well. That they've appointed an infection control lead, but the infection control lead has never been trained as an infection control lead. They've maybe read HTML 105 once and done some updates, but a lot of us are giving this responsibility to be the infection control lead, to make sure the logs are being done, to make sure that the logs are being done, to make sure that the audit is done, to someone who's not trained to do it. Also on that point, with recruitment or something, what you'll find sometimes is that, and I'm talking more to practice owners here who want to delegate this role, is someone will recruit a nurse who's been, and someone who wants to recruit someone to lead compliance, so doesn't necessarily have the knowledge themselves, will recruit a nurse from another practice who was the infection control lead, and sort of and the approach is, well, you were the infection control lead in that practice, so therefore you can manage all of compliance in our practice. So you end up with a principal who doesn't know what compliance is, and somebody who's way out of their depth, supposedly being in charge of compliance. So I'd think about roles that you give to people. If you're, legally speaking, if you are asking someone to be the infection control lead in your practice, if you're promoting someone, then you're responsible for making sure that they're trained. So it's your responsibility, not theirs. So maybe look into infection control lead courses if you query this, and I'll talk more about the audits in a second. So this is the situation that you want to avoid. So this is on a CQC inspection report. It says, the lead nurse had used a template supplied to a company from a compliance, supplied to the practice by a compliance company to carry out a risk assessment. However, she'd never been trained on risk assessing. There's an organisation called IOSH, IOSH. They do a 3-day course that is basically the minimum requirement that HSE thinks you need to have to risk assess in a business. And even after that, Legionella and fire, I am IOSH trained. So is Cliff, our office manager. Legionella and fire, you might need to think about it. So basically, think about who you're asking to do roles that actually are roles in law, like your infection control lead and your infection control lead and and say your people doing risk assessments for you. It's just standardly where people fall down, and anyone doing an audit for you as well is really, really important. So moving past that, so this is what happens, and I'll tell you some things I've seen in the last 2 months. The dental records audit had failed to identify many of the shortfalls we noted, and the radiography audit didn't include grading. So in the last month, I've seen 2 practices where the radiography audit has been given to a nurse. The nurse isn't radiograph trained. The dentist has scored all of their x-rays in the last 6 months a 1, and the nurse thought that this meant it was a perfect audit. Hopefully we all understand the problem there, right? Well, national statistics, and if we speak to the guys who teach IRMA at the CPD and the university level, they will tell you it's impossible to get 100% ones. It doesn't happen. So that nurse who was doing that audit should have actually known that was a problem, actually fed back the dentist isn't scoring their x-rays correctly. Does that make sense? Whereas the nurse went 100% audit, well done, see you next week. And the RPS who was the principal, hadn't signed it off or looked at it, had just reviewed it. So your nurses, I'm not going to go into how it works in everybody's practices, but just think about who you're asking to audit. Have you trained them properly? Are you giving a role that could potentially fail your CQC inspection to someone who doesn't know what they're doing? Do you need to train them on it? Unfortunately, delegation requires training, management, follow-up. I'm sure you all know this as managers, but quite often we're trying to be quick with something, so we'll delegate it, but we won't manage that delegation. So the next one, the audit stated the use of 2 sinks. So this is on an infection control audit, and we've seen myself and Claire, who's been typing, Claire, who's essentially our head of our quality practice scheme. We see this quite often in that someone, either the infection control lead isn't knowledgeable enough to do the audit, or they've sat at a desk and they've done the audit. So they've done the audit going, yes, we definitely do that, and then the CQC come in, take that audit up and go, walk around the practice and go, why have you ticked that? You've said that you've got all validation records, but I can see here there's a week when it wasn't done, and that should have been highlighted, and a week when your autoclave validating wasn't recorded. So it's really, really, yes, and sorry, Donna's just said that on there, never allow anybody to audit themselves, ever, if you can avoid it. Everyone is too nice to each other. What you might like is, if you're not using our latest contracts, our latest associate contracts actually say that the associate is duty bound to help with the stuff that just has to be done in this way, say the auditing. So you might want to upgrade our contracts, and if you're thinking of doing that, you might want to look at the total HR service to help you do that. So moving on from that, poor organisation. This is just a really easy one. I put this slide on it because it reminds me of a practice I went to once where I opened the door, went into the office, closed the door, and I felt I was in one of these libraries from like a stately home. And there were just 300 files. And then when I asked the practice manager, can you show me your risk assessment? She spent 20 minutes not finding it. Which obviously to a CQC inspector, you've shot yourself in the foot. You're the practice manager. You've been preparing for 2 weeks for this inspection. and you can't tell me where something basic is. It just, so, in iComply, hopefully you're keeping it mostly digital in version 3 now, and the stuff that you have to have printed, you're printing off, but just know where it all is, be able to access it really, really quickly. Right, moving on. That's the main bit on the well-led key line of inquiry, by the way: competence, capability, capacity. So time that you're giving it, leadership knowledge, and the people who are in charge of it having the knowledge to be able to delegate it with confidence. And then the people you're delegating to or carrying out the task, then that they are actually competent as well. I'm struggling to get my words out there. So, moving on with this, just a quick chat through this, but a poor governance system will have too many folders, no way of knowing what's changed because you're not subscribed to someone like us who's giving you these alerts and telling you sepsis is a big deal right now. The system's in the manager's head. If you are watching this and you're not an iComply member and your manager is the only person who knows how compliance works in your practice, I'd be very careful, because at least once a year we get a phone call from somebody who has had an argument with their manager, fired them, these aren't members at the time, fired them and not necessarily followed employment law, and then the manager has walked off with the folders and left them in a mess. And they can't pursue it because they didn't follow employment law, so there's a potential tribunal there. So that happens at least, I'd say, once a year with us. So just make sure that you either get them to write it down for you or you subscribe to a system. So important dates getting missed, competence we've spoken about a lot, box ticking without any evidence of improvement. We're about to come on to this. Just ticking the box, not following up. That's where a lot of people fail on quality assurance. This is the other aspect to well-led that I wanted to discuss. Principal doesn't care. It's okay if you hate compliance, that's fine. As the leader in your practice, just don't tell anybody, because I'm gonna say this, I'm stealing this from Chris Barrow, who I think is amazing, if any of you know Chris. Chris says, the culture flows from you, the leader, the owner in the practice, whether you like it or not. If you walk into the practice with a face on in the morning as the principal, the manager, then I can guarantee you within 5 minutes, the whole team is talking to each other and going, he's in a mood, put your head down. And then you've set the tone for the entire day. And with compliance, you do the same. So if you say you hate compliance, you say it's horrible, as you say it, so it becomes, and it becomes horrible in your practice. I quite often say that the practices where the leader is on board with it and they think that it's worthwhile, or at least that's the message they're giving, I can tell that difference within about a minute of being in a practice. I can tell what your personality is like as the manager or the owner within a minute of walking through your front door because of the way your team are just behaving and being, which is, I think, is quite interesting. And no quality assurance, which we're going to get onto. So, structured system. For those of you that don't have iComply, we have a structured system in order to make sure you don't miss dates. Everything's there. You can file it easily. It will tell you where it's been filed. If you are interested in iComply, then please get in touch with us after this webinar as well. One of the best things about iComply is the way that we manage audits as well. With audits, it's really good to understand what you're doing as well. So I'll just put this in a real nutshell. We review our policies and procedures once a year or something like that. We train our team on them to make sure that they're aware of what our standards are. And then we audit to make sure that our team are following the standards. And then the next bit is the bit that people struggle with. The job isn't to do the audit. The job is to find problems and improve and keep your paper trail. Getting to the audit is just the first step. Does that make sense to everyone? I'm sure it does. So you need to follow up. You have to have evidence. It's not just audits. Risk assessments, satisfaction surveys, complaints, safety alerts, all of these things are the data that you need to analyze and move on from and have proof of doing that. So how do we recommend that you do that? That's pretty much what I just said. Sorry, don't just tick the box. So how do we do that? In iComply, this is a feature that I really hope after this webinar more of you will start using, because it's one of the best things we added when we moved to version 3, is the ability to create related to-dos that show on your compliance report. So for those of you who don't have iComply, when you sign off an activity, like an audit, you can write some notes to say what the audit found, and you can schedule and diarise and delegate any follow-up activities, and that whole paper trail is all in one place on your CQC inspection report. So if you look here, this is an example of a completed compliance report in action plan, in iComply, and it says, we carried out the audit, we've scheduled follow-up actions, there's the audit, but then the bit on the right, the related to-dos, that's how they show on your report if you use them. So when your CQC inspector comes in and they said to me, Alex, can you show me the infection control audit? I can just go to the report, I can search for it, it comes up here, I click down, and I can show the inspector exactly what we found. So if your evidence notes when you're signing stuff off in iComply just says carried out audit, the inspector knows that because you completed it. So use your evidence notes to actually say what problems you found, because this is the bit, one of the major bits that people fall down on. And then on the right, you can see what the follow-up actions are and their status. And if they're overdue, they're going to go red and you're going to get reminders. I think that the day of the paper-based action plan is almost over. And because this is such a key thing with quality assurance, continuous improvement, and having to create this paper trail with your compliance, if I was managing a practice at the moment, I'd do it all in iComply, and I'd put it all on the calendar, and it's all in one place, and I'm getting reminders. A lot of our members are still writing the paper action plan, so I'd really encourage you to use this feature, and if you're not sure how to use it, ask us, give us a call. That's what we're here for, Monday to Friday, 9 to 5. So, we are pretty much at the end of the presentation. I've only got a couple of more slides. Thank you for staying on till 2 o'clock. So here's just some tips if you're struggling with some of this stuff, but allocate 8 hours a week to compliance management, or allow your manager to have that 8 hours a week and keep it as sacred time, because 8 hours quickly becomes 16 hours behind, quickly becomes a month behind, quickly becomes 2 months, and that's when the CQC are going to call you. Build flex into your business. If you are having a high staff turnover, then consider why. Have a good look at the practice and yourselves and your culture. Especially in the current market as we are now, where it's harder to find good staff. I'm sure we can agree it's kind of, right now, I think we actually maybe need to improve our cultures a bit because retaining people, it's becoming a lot more competitive, right? Build flex into your business. A practice that I know very well, the principal said to me, I said, well, why have you got these two apprentices all the time? They seem to be sat around and they're not doing anything. And the person said to me, I've had this practice for 25 years. I've done a financial analysis of the last 10 years, and actually it's cheaper for me to have 2 apprentices than to have temp and have that flex in my business than it is for me to have temps in when somebody goes off sick. So leadership, learn compliance. Make sure if you are in charge of it that you know it. Stay up to date with it. Do CPD. Invest in a system. Follow it. Delegate responsibly, but only delegate to people that you are training, that you train them. Either yourself if you know it, or if you don't know it, just be honest that you don't know it, and go on a course and send them on courses. Create a culture of quality. Remember, you're the leaders. Hopefully, if you do all of this, you should become well-led, and then staying well-led.